Good afternoon. I'd like to welcome you to the Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and it's our pleasure to bring you these weekly Medical Center Hours each semester. Our program today is titled Lola's Song, A Family's Journey of Change and Healthcare Transformation After Medical Error. This is also the Jessie Stewart Richardson Memorial Lecture, which has been an annual event at the University of Virginia School of Medicine since 1999. This lectureship remembers Mrs. Jessie Stewart Richardson, whose untimely death 2 decades ago resulted from tragic adverse events in her care at this hospital. Because Mrs. Richardson had had a long career as a teacher, her family chose to invest funds in medical education so that upcoming generations of health professionals at UVA might know better how to invest themselves in care that truly has patients at its heart. This afternoon, as every year, Mrs. Richardson's son, Dr. Don Richardson, joins us for this lecture. Welcome, Don. We're happy to see you again, and this is quite a journey we're on. On behalf of UVA, I'd like to acknowledge not only your family's loss and your generous gift, but also your continuing collaborations with us. It's meant a lot, and I think it's contributed in very significant ways to the ongoing education here at our institution and to the evolution of patient care here. Over nearly 20 years now, the Richardson Lectureship has sustained a conversation on the sensitive subject of communication about medical error, its myriad repercussions for patients, families, and health professionals, and its impact on the quality and safety of care. A couple of themes, medical error and patient safety, have been addressed several times by leading national experts in this lecture series. But another Richardson Lecture theme right from the start has been simply the matter of attention to the patient. In many of our presentations, though, these themes have intertwined powerfully to make the case that the best care, the safest care, derives from compassionate attention, careful, precise communication, and respectful partnerships among professionals, families, and patients. This Richardson Memorial Lecture's origins are the hospital death of infant Lola Jayden Fitch and her family's journey to evoke change. This hour will be anchored in the stories of Lola's parents who are with us today. Her mother, on my immediate right, musician Cathy Motley-Fitch, who questioned her intuition, and her father, physician assistant Alan Fitch, who chose to continue working in the hospital where his daughter's death occurred. The Fitch's presentation will also review for us the medical staff communication errors that tragically affected Lola's care. Together, then, we'll explore how Lola's song and similar stories, those of patients, families, clinicians, and others, can help us to accomplish the all-important work of clear communication, better teamwork, and true partnership with families, all in the interest of better, safer patient care. I'd like to thank the Office of Quality and Performance Improvement in the UVA Health System and Dr. Tracy Hoke and Mr. Jarrell Jacobs for partnering with us on this program. And lastly, I'll mention that Ms. Motley-Fitch and Mr. Fitch had no conflicts of interest to disclose. So welcome Cathy Motley-Fitch and Alan Fitch and Lola's song.
Well, I've never had a tough time following the introduction, but that was, Marcia, thank you very much for that. I'd like to take a minute to thank Dr. Richardson for having us here and the staff at UVA for bringing us here for this talk today. I'd like to start off this talk by getting to know the audience a little bit better. I know healthcare is quite a commitment. It's a lot of hours, it's a lot of stress, a lot of pressure. for sometimes little or no thankfulness. So I'd like to get to know why a couple people even chose medicine as a career, and this is kind of where I pick on people, and I understand you're pre-med, so I'm going to ask you first. Right in the middle of your lunch, I'm sorry. Just tell me your name and why you chose medicine as a career.
Hi, I'm Rebecca. I'm a fourth-year global public health major, bioethics minor. I've wanted to be a doctor since I was 4. I have this really cute picture of me in a cute little white coat with my mom's stethoscope. So I think it's always been something that I've talked about a lot. I've always had dinner table conversations about LVADs and atrial fibrillation. So I've always really been interested in caring for other people, and that's been something that I think I can do best through the healthcare realm. So.
Thank you very much, and that's a perfect answer. And we sometimes wonder if healthcare is a calling or something we just fall into, but a lot of times when we ask people, they've known from the start that they wanted to become some type of healthcare professional. Any residents in the room? Residents, fellows? They're not going to raise their hand now that I've asked them. There's one. Same question to you. Can you tell me your name and why you chose medicine?
Sure. I'm Numberta. I'm a third-year NHP fellow.
We're bringing you a mic.
Oh,
Here we go.
I probably more fell into it, like you were mentioning. A lot of times when we are in undergrad, you like science, you like helping people. Medicine seems like the right direction to go in. And then I think over time, once you start and actually realize what you've gotten into, you develop a love for it for other reasons, and that becomes about helping, well, for us, helping parents and helping patients. But it starts with, I like science and I'm good at it, I like service and I'm good at it, so why not?
Thank you so much. I really appreciate you guys' feedback. Cathy and I have been doing this talk for a few years now, and some of the other reasons we hear is at some point a healthcare provider has had an impact on them or a family member, and the number one reason we hear is, I want to help save lives. It's a big responsibility, and sometimes I think for those of us who have been in medicine for a while, we forget that. We get up, we get in a routine of taking a shower, get to work, and don't remember that every decision we make that day can have an effect on somebody's life. And most of the time, thankfully, those decisions that we make on a daily basis have a good result. But what happens when it doesn't? What happens when a decision we make or our team member makes causes harm to a patient, or even worse, causes a death? Does anybody in here, just raise your hand if you know the number of medical deaths caused by medical errors in the United States alone last year? If you don't know, take a guess and you can yell it out. And that's 200,000. Anybody else?
1 out of 9 patients.
I can't do the math on that one. In 2016, there were approximately between 210 and 400,000 deaths caused by medical errors in the United States alone, making it the third leading cause of death in the country, right behind cancer and heart disease. We learn about cancer, we learn about heart disease, we learn about pulmonology, nephrology. We don't learn this. We do this talk all the time, nobody knows that number. Some people say we're getting smarter, we have more information at our fingertips. This number has got to be getting better. In 2009, there were between 50 and 100,000 deaths caused by medical errors. So according to statistics, it's getting worse. And I know these numbers can be manipulated, but let's say they're half right. Still a lot of people. So why does that number matter to us? Because our daughter was one of those numbers. I always have a tough time with this. On June 5th, 2009, our daughter Lola Jayden Fitch died at MCV Hospital, but now is known as VCU Health Systems. Today you're going to hear Lola's story. Her story is going to be told by my wife, a mother who lost her daughter due to a series of medical errors, misdiagnoses, and a lack of communication from her healthcare team. You also hear it from me, her father, a healthcare provider at the very institution where this event took place. Many of you have more than likely been to a presentation that heard a story like this before. There's thousands of them. I truly believe these stories can make a difference. Through all the studies, the numbers, the statistics, healthcare providers need to see the impact that these events have on families. We're thankful for each one of you to take the time out of your busy day to hear our story. But more importantly, we want Lola's death to be a reason for change. We hope it will educate you on the toll medical mistakes cause on the healthcare system and the families today. We want to challenge each and every one of you here today to make changes in the system that allows this to happen. And most of all, we want to empower each and every one of you to speak up when you have a gut feeling that something just isn't right. I've been a physician assistant for about 16 years now. The past 12 of those years have been at Virginia Commonwealth University Orthopedic Department, where I still work today. My wife and I have been married for about those same 12 years. Some point, like most marriages, still question the decision today, but the topic of children came up. Cathy and I had put off children and marriage to later in life, and we figured it was about that time. So in October of 2008, we found out we were pregnant. Not only pregnant, but pregnant with twins. The story became even more surreal that one was a boy and one was a girl. It was like the best laid out story we could ever imagine. There are two things that we decided right away. One was Lola's name. Cathy knew ever since she was a little kid that if she had a daughter, she would name her Lola. The second was more of my decision, that the babies would be born right there at VCU Hospital. Seemed like a logical thing to me. I'd been there, everybody knew me. I could handpick the people that were going to be involved in the babies delivering care. I worked one floor beneath so I could be there within a moment's notice if I needed to be. Cathy, however, had some reservations about going to a teaching hospital. But with a whole lot of convincing, she agreed it would probably be better. We met our labor and delivery staff and toured the brand new state-of-the-art NICU that they had at VCU.
Okay, so I need to back up for a quick second. When I see the slide that says the third largest cause of death in the US, heart disease, cancer, but then mistakes, it boggles my mind. Dr. Richardson, you've been doing this, it was 20 years ago, was your loss? 20 years ago. What was 20 years ago? What year was that?
It'd be 2008.
2008?
No, I'm sorry,
No.
1998.
1998.
I'm trying to act like I was smart there for a
And
second.
then in nine, they're 50 to 100,000, and now they're 200 to 400,000. And that could be because of the way it's reported, I understand, but no doubt the number's increasing. Alan has PA buddies that are like, how long are you all gonna do this talk? How long are you gonna keep, no offense, but you've got two boys. Why don't you just focus on them? And believe me, by being here, we are focusing on them. They know we're here, but we're gonna speak to you in hopes of you doing your job better and us sharing Lola's story to make a difference. We both looked forward to every appointment. We stared in amazement at each ultrasound of these little twins. I read every childbirth article I could get my hands on, and Alan took daddy boot camp classes. He also watched his banking account dwindle in preparation for twins. I was about 27 weeks pregnant. I was experiencing some discomfort, went to the doctor, had my dad drive me down to the doctor, who immediately admitted me for hospital bed rest due to preterm labor. I wasn't even allowed to go home and get clothes. After 5 or 6 weeks on hospital bed rest, never getting to leave, on May 29, 2009, the babies were born at 32 weeks. The delivery went well, and we finally got to meet our two babies, Grayson Howard and Lola Jayden. They weighed 3.7 and 3.5, respectively. As with all preterm infants, they were admitted to the NICU for observation. They required no respiratory assistance and were called feeders and growers, which some of you know, a term used for infants that are just there in the NICU for observation and to mature.
The first day in the NICU can be a scary experience for parents. The alarms, the monitors, and just the fact that your babies are in the neonatal intensive care unit can truly be overwhelming. Cathy and I stayed with Grayson and Lola as much as possible. We held them as much as the staff would allow. Cathy would sing lullabies to them for hours just to let them know we were there. Their favorite song actually became Bob Marley's Three Little Birds Don't Worry About a Thing. I worked one floor beneath the NICU, so I was able to be with them several times throughout the day. My wife and I slept on the fold-out couches just to be close to them. We asked the staff questions, participated in their daily care, and attended rounds every morning. We became those parents that just wouldn't leave. After 3 or 4 days, we had developed somewhat of a routine. The alarms and monitors did not instill the same amount of fear they did the first couple of days. Our babies were doing well, and we were adjusting to life in the NICU. They were born on May 29th, and on the morning of June 4th, I told Cathy to stay at home, take care of some things that needed to be done, and I would call her as soon as rounds were over just to keep her in the loop. I waited as the medical and support staff made their way to Lola and Grayson's room. Started out like most mornings, a discussion of labs, and pertinent medical information such as feedings. However, on this particular morning, a third-year resident expressed some concern about Lola. She asked the attending on duty if a workup could be done on her. Kind of caught me off guard. I wasn't ready for it. The attending was sitting right beside me, and he asked why. And this is important. She said overnight that Lola developed a number of bradycardias, on several occasions become apneic, and had shown signs of mild feeding intolerance. The attending looked at her and said, "No, don't worry, that's what preemies do." Looked back at me and said, "She's fine." I felt great. This attending with 25 years of experience in the NICU was sure to know more than any third-year resident would ever know. However, what really didn't occur to me at the time is nobody in that group of 15 or 20 people took the time to go in there and examine Lola before they moved on to the next room. In fact, after going through her medical records, it was discovered that attending did not examine Lola for the 12 hours surrounding that time period.
So on June 3rd, it showed no signs. It's about a week into the NICU, and it showed no signs of being different than any other day. The nursing staff convinced Alan to take me home and to treat me like a princess. They said they would keep an extra eye out for the babies. They mentioned that I needed to rest because there wouldn't be any once we got home with twins. I was very nervous about leaving them overnight. Like Alan said, we had slept there, and I'm a little type A, as most moms are. The next morning, I made sure that if we went home, that Alan would be there for rounds. I woke up at 6 a.m. and called the nurse to make sure everything was okay. They said they were great. I called numerous times throughout the day, making sure everything was fine. When I called that evening, I was told that the staff was busy and asked if I could call later. So I called back around 10 p.m., and I finally spoke with a resident covering the NICU, who casually informed me that Lola was experiencing some signs and symptoms of something called necrotizing enterocolitis, NEC, often coined in the NICU.
For those of you who are not familiar with necrotizing enterocolitis, a pretty common condition that they look for in premature infants. The signs and symptoms, the definition of necrotizing enterocolitis is inflammation and death of intestinal tissue that may involve just the lining or the entire thickness, and in severe cases may cause the intestine to perforate, causing bacteria to leak into the abdomen. Signs and symptoms, you've already heard 3 of them. Bradycardia, apnea, feeding intolerance. As the disease progresses, the child becomes lethargic and blood is present in the stool. How do you treat it? Stop feeds. Gives the bowel time to rest, antibiotics to fight the infection, and an NG tube, which also gives the bowel time to rest.
So the resident explained that they had intubated her to make her more comfortable, and she was being monitored closely. I hung up the phone, very comfortable, and then I turned to Alan and I was like, "What does intubation mean?" I had no idea. I'm a vocalist. I didn't know what intubation meant at that time. He was immediately alarmed, and we jumped as fast as we could into the car. We were angry and scared that our 5-day-old premature infant was intubated without us being notified of any change in her condition. Remember, I called at 7, and they were too busy to talk to me. They were intubating her at the time. We asked to speak to the attending, and we were told he was on his way in. Upon our arrival, we were shocked at the appearance of our daughter. She was intubated. She was pale and looked nothing like the baby Alan had just seen hours before and I had seen the night before. Alan immediately went to the computers on the floor and started doing research on neck, while I reached into the isolette and I desperately tried to massage, Lola's foot to help the nurse get a blood sample. The fellow explained to us that this condition was usually self-limiting with treatment. He said that they were following the correct protocol in her care. We again asked where the attending was, and were told that he was aware of the situation and he was making all treatment decisions. They assured us that he would be coming in if there was any need for concern. Throughout the night, Lola's condition deteriorated. Alan and I continued to request the attending physician be present. Yes, fellows and residents do good work, but when your child is declining right in front of you, you want the best of the best to be managing their care. At one point, I got the med student and the resident out in the hall, and I calmly pleaded, but then I demanded that they call the attending and stress how important it was that he be here with us, that he come in with my daughter. But the resident then proceeded to give me a lecture on the chain of command. She replied it was not her place to ask and call him directly. It was obvious by that time, though, that the fellow and resident were becoming increasingly concerned and they were losing control of the situation. Alan and I watched in horror as the sequence of events that eventually took Lola's life unfolded. We listened as a nurse argued with the resident about wearing a bracelet in the NICU. They couldn't call the attending, but they could stand and have a verbal disagreement about wearing a bracelet over my daughter, taking precious moments away from her care. And then we watched in shock as the fellow looked across the room and he saw the antibiotics he had ordered hours before laying up on the counter, forgotten and unadministered.
At approximately 4 a.m. that morning, the fellow noticed a significant change in Lola's condition. Her bowel had become distended, and he was afraid that the bowel had perforated. A stat KUB x-ray was ordered. The x-ray technician came up, took the x-ray, and stated that she wanted to take an x-ray on another patient on the same floor before taking the time to run our daughter's films down. The fellow insisted he was very concerned about Lola and they should be taken immediately. Once again, another verbal disagreement took place right in front of us. After about a minute, I interrupted and told her if she didn't take him, I would take him down myself. At that point, she left the room, slamming the door in frustration.
That reading confirmed our worst fears. Lola's bowel had indeed perforated, and an immediate surgical consult was brought in. The surgical resident evaluated the x-ray, as well as our daughter, and informed us a drain had to be placed in order to extract fluid from her abdomen. We signed the consent form and preparations were made. However, within minutes, her condition worsened and a code was started. I will never forget the medical student who was asleep with her ankles crossed on the desk in front of my daughter's room as the lights were flashing and people were flying in. I can't repeat here, I'm sorry. Forgive me, I can't repeat what I said to wake her up, but I woke her up. They finally rushed to place the drain, but standing outside the room, we overheard that no scalpel was brought in on the surgical tray. They could not find one. We watched in disbelief as staff members ran around trying to locate a scalpel. A nurse was frantically searching the room and the nurse's station. I took off, ran through the doors of labor and delivery, begging anyone for one. I watched in horror as the NICU doors then locked shut behind me. I was begging anyone for a scalpel when finally a med student happened to be walking by. He heard me and had one. He flashed his badge to open the door, and we ran to Lola's room. However, by the time we got there, it was chaos. Her condition had deteriorated rapidly. And a short time later, Lola died in my arms.
That night, our life was literally turned upside down. There's so many emotions running through a family's mind at that time. There's anger, confusion, grief, but the true feeling of helplessness, especially for a healthcare worker, was truly overwhelming. Two things stick out in my mind about that night. First was having to tell both sets of grandparents as they walked through the door that their granddaughter just passed away. But by far the hardest thing I had to do was tell Cathy to let the staff take Lola from her arms and knowing that she would never see her again. The next few hours were spent with the devastating task of calling family and friends, talking to clergy, and planning our daughter's funeral, all the while with Grayson still in the same room. That morning, shortly after her death, we had a discussion with the oncoming physician. It gets a little complicated. Lola died about 6 a.m. in the morning. The new on-call attending was supposed to come in at 7. He explained to him that the attendant on call that night had phoned him and asked him to take over his call a little bit earlier because he was leaving on vacation earlier than expected. He said he got ready to come into work, received a phone call about Lola's health deteriorating. He said he got in his car, got halfway to the hospital, received another call letting him know Lola had passed away. So as we sat in this room and an hour after Lola's death, this attending looked at us and said, at that point, I didn't see any need to rush in, so I turned around and went home and had a cup of coffee with my wife. He then proceeded to inform us a little bit about NEC and answer some of the questions we had. He claimed that he did not know why the attendant on call that night had not come into the hospital, but he was not really in a position to question his decision. That attending made no effort to contact us for the 10 days while he was gone on vacation. Think about that for a second. A young infant under your care, the daughter of a hospital employee died, and you made no attempt to contact that patient's family for 10 days. When he did return, he met with us for a short informal meeting in Grayson's room. His explanation for not calling us was that he didn't have any cell phone service where he was at on vacation. He expressed his condolences and asked about any concerns we may have. Obviously, our first one was, why didn't you come in that night? He looked right at us and said, in hindsight, I wish I would have, but remember that VCU is a teaching hospital and I have to give my residents and fellows enough rope to learn, but not enough rope to hang themselves. So two attendings with over 20 years' experience have now told us they turned around and had a cup of coffee with their wife and that the residents' and fellows' education took priority over our daughter.
Grayson remained in the NICU for about 5 weeks after Lola's death. I can't begin to tell you how difficult it was to go to that NICU every single day and sit near the room where our daughter had just died. We fought on several occasions about having Grayson transferred. I wanted him out of there. But Alan felt, after what had happened, that all eyes would be on Grayson and he would receive the highest quality of care, which I understood, which I agree with. And in most instances, he did. There's a moment where professionalism was lacking that I share just to make you think. A close friend and I were in Grayson's room. The nurse in charge of Grayson's care came in to take his vitals and change his diaper. She agreed when I asked if I could help. I hadn't had that opportunity and I didn't really know what to do. I was pretty scared to touch that baby a lot. She said, sure. However, within a second, she received a phone call on her personal cell phone. And so she went over to the isolette, she put the phone on her shoulder, took his vitals, changed his diaper, and planned a trip to Miami with her husband. I remember they were on their way to Miami. We watched in disbelief as this went on for several moments. She never looked at us, much less let me change my son's diaper. She waved and then headed out. With all that had happened in that hospital, on that floor, to my family, I couldn't believe how easy, how quickly we get into our own lives and have such a lapse of judgment. However, like I said, for that one careless mistake, the majority of the nurses taking care of Grayson were excellent. He did well for the remainder of his stay, and he is now a happy, very cheeky, healthy 9-year-old.
I cannot express to you enough the toll the death of a child takes on a family. Cathy and I handled Lola's death very differently. We both attended grief counseling, spoke with people from our church, and had both, luckily, had a strong family support system. I only took 1 week off of work at that hospital. I needed some normalcy in my life. But from the start, my wife had a strong motherly instinct and insisted all along that something was not right about that night. Too many things had gone wrong. I did my best to push away the feelings of anger and guilt that I was having about myself. I told myself bad things happen at hospitals, and this time it just happened to us. It put an enormous strain on our marriage and our ability to enjoy our time with Grayson. He had just lost his twin sister, and now his parents were struggling how to cope with that loss. Several months went by before I had any contact with the physician that was on call that night. Seems kind of odd. We work at the same hospital, but like UVA, it's a big place. However, while walking down the hall one day, I saw him approaching me from the opposite direction. There's only two of us in the hallway. He knew me, I knew him. I knew without a doubt he was going to stop me, ask me how my family was doing, and let me know how everybody in the NICU was thinking, that they were thinking about us. However, without missing a stride, he walked right by me and said, "How's it going?" I literally felt like the wind had been knocked out of me. I don't know if I was more mad at him or more disappointed in him as a doctor. But I will tell you that the chance meeting in the hallway that day started the chain of events that brought us here today. I immediately went home and pulled out Lola's medical records and started reviewing them. Labs, feedings, any other pertinent information. I spent days sitting at my desk and reviewing the days of her short life and her death. The more I looked, the more obvious it became that she was sick. And she was so sick and tried to tell everybody, but until it became too late and it was ignored. I put these slides up to kind of prove a point on communication and how important it is for handover and turnover in the way medicine is changing with texting and electronic medical records and everything that we do in hospitals these days, but it still boils down to communication. She was born on May 29th. From May 29th to June 2nd, she was doing very well. There was no alarms, no any kind of concern. On June 2nd, at 1700, doctor aware of bradycardia and apnea episodes. No intervention ordered. Farther down the notes, residual of 6 millimeter partially digested formula remaining from last feed. Nurse practitioner notified. Told to discard off new formula, 2400, give her another feed, no new orders given. Right below that, will continue to monitor abdomen and feeding tolerance closely. June 2nd, somebody's already thinking about neck. You're in a NICU, it's something we look for, and a nurse noted that they should keep an eye out for it. MD informed of second episode of emesis prior to remaining this feed, no new orders received. June 3rd, patient having bradycardic episodes is noted, MD notified, no new orders. It's 4 notifications in one day. Patient appears lethargic. Now you've got 4 out of the 5 symptoms that we noted previously. Bradycardia episodes requiring mild stimulation. She's starting to get worse. What are we going to do instead of stop feeds? We're going to increase feeds to 30 millimeters every 3 hours per order. Farther down, bradycardia episodes with desaturations, continues to have bradycardia and desats. June 4th, the morning the third-year resident expressed some concern and asked for a workup to be performed. Patients had a couple bradycardia episodes. What are you going to do? Increase feeds from 30 to 53 millimeters every 3 hours. Patient continues to have occasional bradycardias. Patient had another small emesis, stop feeds. So right here, somebody else was thinking about something, stop feeds. MD wear small 2 emesis, attempt to give remaining 5 millimeters at next feed. So you've increased the feeds twice, she's not handling it, so you're going to pile that on the next feed. Infant is now agitated, stool noted to be yellow with a small amount of blood. MD notified, this happened to be a second-year resident. Infant examined by physician, questionable anal fissure noted. Infant remains agitated. Aspirate noted and feeding held per MD at 21:15 and feedings were held again. 10:15, they offered to feed her again. That's when they intubated her. I know we could go through every patient's medical records and in hindsight find things wrong and find clues, but when they're noting it, that they're looking for it, in something that we look for in premature infants, going back, it's just kind of overwhelming to me that it wasn't caught sooner.
Alan often reminds me that if every single thing had run perfectly that night, that Lola still may not be alive. And I understand that. I hear him say that, and I understand that. My gut tells me differently, but I understand. But what I know for sure is that she deserved better. She deserved to have a trained attending by her bedside. She deserved to be watched better and taken more seriously. And then we deserved the sympathy and respect given to parents who just lost a child. Getting up here and telling our story is painful. There are many days when I rub my eyes in disbelief that my daughter is gone. What do you do with that? What do you do with all those dreams, with that pain? For me, and for us, our choice is to make that life matter. We will never celebrate the milestones that our little girl should have, but we will make sure that her voice is heard. Her story will make a difference. And in a way, it's amazing how much good that this child has already brought into the world. We had to resolve fear about having more children. And what do we do with that? Where do we go? And Lola's second brother, Sawyer Graham Fitch, was born on May 23rd, 2011. He is a mess, is what he is. Her brothers deserve to know that every possible thing has been done to understand and rectify the circumstances that took their sister. They ask all the time. They need to know that when they go into the hospital for any type of care, that they are safe and they are protected. Wouldn't we all like to feel that way? This starts with us speaking out, and then it starts with you. If I don't put my all into my singing, it's not the greatest performance, and you may not recommend my show. But when you don't put your all into a patient, there is a possibility that they can die. And at some point, unfortunately, you may lose a patient. I'm sure many of you already have. And when that happens, I'm sure someone will tell you not to beat yourself up, and it happens. It happens in our profession. You have to self-preserve and compartmentalize. But the minute that you just shrug and accept that it happens, I don't think you're doing your job. And that is not acceptable. It doesn't just happen to a mother losing her child or an 85-year-old losing his spouse, especially when it may be due to your team's mistakes. Your team's mistakes. You have the chance to change the future and to prevent mistakes from happening. I realize the esteem that comes with a profession in healthcare. It makes your families and yourself proud. It'll possibly give you resources for a nice, comfortable life, but it's so much bigger than that, and you know that. You all are the ones that save lives. You find cures, and you can help or stop the number of medical errors that take hundreds of thousands, not tens of thousands, hundreds and thousands of mistakes that take patients' lives each year. We come here for help, but mistakes happen. My job is fun and exciting, but yours is exciting, and it is so important.
I think it's important to point out that this talk has not been to criticize or place blame on any individual in that department. Medical mistakes happen each and every day at the best hospitals across the country. That's why Cathy and I felt it was important you hear our story. We want to challenge each and every one of you here today to become part of the solution and not be part of the problem. We're asking as a group that we help start a movement that will make the loss of life suffered from medical mistakes occur far less frequently than it does today. This presentation isn't about feeling sorry for Cathy and I. It's about you and what you will do to use this information to become a better provider. Each one of you either work or will work at a hospital much like UVA, which has an excellent reputation. But don't think that's going to make you a great provider. Being a great provider is more than treating an illness or fixing a broken bone. After being in medicine as long as I have, I still believe that there's a true talent to practicing medicine. It involves listening to what their patients and families are telling you, and always know that nobody knows that patient better than a family member. You don't want to have to sit across from me at a table one day and tell me my child would be alive if you would have done your job better. Stop, listen, think, and act. It's getting back to the basics of medicine. That is what we all need to do from this day forward for every patient every day. Better thought process, much better communication, and better teamwork. Today, we all can start as a group to start reducing the number of medical errors that occur each and every day in our hospitals. It's not just our job, it's our responsibility.
So people often ask us after our talks, what did you need to hear from the hospital? What did you want to hear from the hospital? What I needed for my soul was an apology. I wanted an apology. And then I needed a promise. I needed a promise that doctors and healthcare providers would do better. I thought about what was lacking in Lola's care. I thought about it. I think about it all the time. What was lacking? What could have changed? What I wanted for my family from my doctors, my medical team. And I came up with something called Lola's Pledge. I thought of the things that I wanted. I wrote and wrote and wrote. I asked Alan, as I do, if I was demanding too much. Am I asking too much for you all, for doctors? I had heard people say when you go into the hospital, you have a choice. You cross your fingers and you pray and you hope for the best. Or, I often hear this, you just expect the worst because the hospital is the last place you want to be. But I make it a practice not to expect the worst. I don't raise my family that way. And I can assure you, when I left my babies on June 3rd to be treated like a princess, I was not hoping for the best. I expected the best. I knew they were going to be fine. I knew everything was okay. Okay.
One step ahead.
Sorry, I was in my head. So, you can, if you want. Did you show the slide earlier about please sit and don't open up your cell phone? You didn't, okay. So if you have your cell phone, feel free to screenshot. Feel free to take it out now and take a screenshot. I've learned when I forget things, my grocery list, whatever, I always have my phone. So you are welcome because this is the part of the talk where I ask you to do something. This is how we make our talk different. We're going to tell a story. We've told a story much like ones that you've heard before. But we're going to charge you to do something. So read over it for a quick second. Studies show that you are 65%, I share this with my vocal students, you are 65% more likely to achieve your goals if you commit to someone or something. And then if you have a specific accountability appointment with someone, then you have a 95% chance of success. I've been asked, what is your confidence level in the healthcare system now? My confidence rises when the number of pledges rises. So we have a website, lolasong.com. And on that is a tab that says, take the pledge. Let me reiterate. Let me say, this does nothing for me. This is for you. This is for you. This is to give you a chance to stop and think and listen and act. My confidence rises when the number of pledges rises, because then I know that people that are hearing our story are taking it seriously and that it matters to them and they will be better. I believe in commitment. We're here as a vessel to share Lola's story, but we believe that you are here because you want to be better and you want to do your best. You'll go back and teach your team members, may they be your family members, whatever team you have, to be better at their jobs and drive change. While I was reading over Lola's pledge recently, I was also watching a video on the 5 things that make great leaders. Now, forgive me because Alan said, "What on earth does this have to do with this talk?" And I said, just bear with me. This means everything about this talk. 5 things great leaders do. Can you go back to the pledge? Okay. Number 1, great leaders, they open and proactively seek feedback. They're not afraid of hearing the truth. They're not defensive or angry. They take it all in as information. I will communicate and listen to my families, my patient, and my team. It's parallel. A leader creates a safe space for people to voice their concerns, their ideas, and feedback. They listen without any type of prejudice. Therefore, letting their team members listen to my intuition, I commit to trusting my intuition and escalating a case no matter the repercussions. Number 3, a great leader listens well. I will take time at the bedside, getting to know my patients, my family. I will take time at the bedside, getting to know my patients better. A good leader understands they have the opportunity and the ability to respond differently to every situation. Events are neutral, but their response is crucial. They can make a situation, their response can save a situation or make it worse. I will practice with a kind and gentle heart, serving my patients with dignity and respect. You see, I believe it's about teamwork. The themes lacking in Lola's care were commitment, communication, empathy, teamwork. And making great leaders within our team makes our medical teams better. We are challenging you today to partner with us by promising to practice better and safer. Be great leaders that will make great teams and stop medical errors from happening today. Helen?
She went on a roll there. I didn't want to stop her. I hope you take the story and whether it affects you today or it affects you an hour from now when you get back in the hospital, or if 10 years from now something clicks in your head or a medical student asks you a question or brings something to your attention, I hope you think back on this. And if it happens once, then I feel like we've done a good job doing this. We appreciate your time. I know it's a busy day. We really appreciate your time and your attention. We've got about 10 minutes for questions. Any questions you may have, we'd be glad to answer them. But thank you very much.
Thank you so much. What a powerful story. And what a pleasure and privilege to have you here.
Thank you.
And we thank you not only for the story, but also for the challenge for us to acknowledge that we are moved and changed by the story and moved to act. We have mics to bring to members of the audience who may have comments and questions. And I will just start by saying in your handout, not only is there the website for Lola's song, but also some other references that have to do with using stories, using narrative within healthcare operations and administration to teach and to help foster change and to pay attention not only to our patients, but also to the ways in which we communicate and interact with one another. So with that, the floor is open for your comments and questions. Please identify yourself when you get the mic.
Sure. My name is Rick Shannon. So I'm the Executive Vice President for Health Affairs here at UVA, and I really want to thank you for coming to share this story. As you pointed out, the numbers are astonishing and to us in many ways daunting, but they become truly meaningful through the kind of story that you told, the real life story, the real life tragedy of losing your precious little daughter because of the imperfections that exist in the systems of care that we have today. And I think it's only through these stories that we can fully re-engage in the really tough work of eradicating those imperfections. The stories are enormously powerful and take on, meaning, I think, to people in this room that no amount of statistical data could possibly impart. So not only would we like to encourage the people here today to sign on to Lola's Song's pledge, but tomorrow and every day in our daily gatherings around safety and quality, and to convey to all our colleagues the opportunity to hear this story and to take the pledge. And through doing so, to really rededicate to creating the systemness and the teams and the humility to listen even when we think we know. As hard as we do, we work at this, it's only when we're confronted with stories like yours that I think we can truly become motivated to fix it. So thank you very much, and I'm sorry for what happened, but you need to know you're making a difference, and that both here and across the country, places are listening to Lola's song.
Thank you very much. Thank you.
Don't know if I can speak well or not. Don Richardson. This is the first time I've ever taken a mic after one of these lectures. Very well done, extremely well done. I was impacted by it more than I've been with anything in the last 19 years since going through this with my mother under the same circumstances. But you folks have explained it in such a way to follow Dr. Shannon very poorly in emphasizing you've done it with humility, but with clarity. And the one thing that I'm going to get in trouble with, because I'm sitting so close to two of these great physicians at UVA, I think that every medical student in this university and every medical student in every university in this medical center in the country needs to hear this lecture. I don't think there's any way in the world that physicians, would-be physicians, can learn more studying cardiology or biochemistry or whatever we've got to do. But I think every medical student needs to hear this lecture. Furthermore, and this is not quite as sure, I think every intern, fellow, resident, and I dare to say it, every staff member in a medical center needs to spend 1 hour listening to this lecture and your story. I think it would make a great impact, and if you want to see that number starting to go down from 210,000 to 400,000 and start to go down, it's when people have an opportunity to come face to face with your tremendous story. I thank you immensely for what you've done and how you've done it. Thank you.
Thank you.
Thank you very much, sir.
Thank you.
And
Other
s-
questions, comments?
And so to speak to that,
go ahead.
though, too, is we needed to do something. Not everyone has the opportunity. Not everyone has the voice. And so we are able to share our story. We wanted to do something, and so did you. And so you created 20 years ago this opportunity. And so us making change is because of you, right? They gave us the opportunity. And so we're so thankful We're so thankful for that because it doesn't matter if it's 9 years or if it's 20 years. You feel it. You know you feel it. It puts you back there. But what you do is you take that and you make change. We smile. You smile. I saw you when you came in today and laughing and saying hello. We still can be happy people because we're doing something. We're trying to do something. And so we are very, very humbly grateful to you.
Hello. So my name is Janice Park. I'm a fourth-year medical student. Thank you so much for coming to share your story with us and share Lola's story with us. So my question is for Mr. Fitch. I was wondering how this experience has kind of changed the way that you practice now, especially at the same institution. I would imagine that that would have been rather difficult to sort of start and then get back into the routine of things.
Let me answer that in two parts. First is I get the question of why I stayed. And that's kind of a long, drawn-out answer, and I'll make it a short answer. The short answer is I could make a difference. I could have gone to another hospital. Number one, it'd been hard to find a hospital that didn't have a medical mistake associated with it. Second, you heard me talk about the chance meeting in the hallway that day with that attending. I had put off looking at her medical records. I had put off all the yelling from my wife that we have to burn the building down. I had put off all that stuff. But when the impact he made of not just stopping me and saying, hey, we're thinking about you, made me go back. 24 hours later, I wrote a 7-page letter to the CEO of the hospital, chief medical officer, chief nurse officer, and I hand-delivered on each one of their desks. And within 24 hours, I was in meetings. They didn't know anything about it. It was listed as a death of neck. But they embraced it. And they are a lot of the reason why we're here today. They said, we want you to tell this story because we came up with the idea of telling it. And we actually do it at VCU, and it obviously does not shine a very bright light on them. How did it change my practice? It made me better. That's the short version. It made me better. I listen to people. I listen to their families. I take time. And obviously working at VCU, I work with a lot of medical students, a lot of residents, a lot of interns. And you get all these ideas that no matter how they're taught or who they're taught from, you get ideas, and I see the hierarchy. And when my wife explains that she got this lecture about I can't go over the fellow's head to call the attending, I still deal with that today in surgery, in orthopedic surgery, where I know somebody's making a mistake and they don't want to call the attending, so I stop them. Orthopedics is pretty basic. You put two things together, you put a screw across it, and it's fixed. But I'm telling you, and for you med students and interns and residents, fellows here, use your voice. There's somebody there. Nobody's going to think bad about you. Nobody's going to question you. And it's so much better than being the person that I'm up here talking about. If that third-year resident that voiced an opinion that morning, if she would have came up to me later or gone to another attending or just felt that gut feeling and told somebody, hey, he told me it wasn't anything to worry about, but I think it is, we wouldn't be here. So working at VCU, much like UVA, we have all sorts of population, from people coming off the streets to the highest people in Richmond. I treat them all the same. And I don't know that I did before this. I would brush a lot of people's stories off, but being now part of this, it's made me listen so much better and understand that no matter where you came from, where you're at in life, that you have a story and you're important to somebody. So I want to hope that I'm a much better practitioner because of this. Unfortunately, because of this. I hope that answered your question. I tend to kind of roll on, but yeah.
No, that was wonderful.
Yeah.
We're at the end of our hour, but I hope that everyone here and everyone who sees the recording of this program understands and is moved by Lola's song, takes that pledge, and takes the story with them. And as you were saying, whether it's an hour from now, a day from now, or 9 years from now, that what you have done in loving memory of your daughter will change the way we care for one another. So thank you, Alan Fitch and Cathy Motley-Fitch. Thanks so much.
Thank you guys very much for taking your time.
Thank you.
Thanks.